Hi, welcome back. It's Dr. Helen from Dorset Allergy. So in this little video, I thought I'd talk about allergy testing, something that everybody wants to know about, something that whenever I tell somebody that I am an allergist, then they always say, oh, I'd love to have allergy testing. And then that's usually followed by me going, why, do you have any problems? Oh, no, I just want to know what I'm allergic to. So that doesn't work, and I'll explain why. So first of all, really important to know that there are only 3 validated ways of testing for IgE mediated allergy. So only 3 approved ways. So that is with a blood test that is looking at an IgE against something. So say IgE to grass pollen, IgE to cat, IgE to peanut or to milk. So something specific, okay? And that blood test can be arranged by your GP or from a hospital setting, and some private clinics, obviously. Or there's this allergy skin prick testing, which are generally only done in a specialist clinic. So it might be in a community clinic, I do them at my private clinic, or obviously in an allergy setting. And then finally, the gold standard, i.e. the best way of diagnosing allergy would be with a hospital food challenge. And I believe there is like a couple of private hospitals that will organise it, but mostly they're going to be done in an NHS hospital. The challenge you have is that if you Google allergy testing, you will find loads of places on the high street that offer allergy tests that are done by people who are not even doctors, for a start. So they don't necessarily know what they're talking about when it comes to allergy, or even more worryingly, sometimes they are done by doctors and they are not validated tests. And there's a really useful leaflet about allergy testing on the British Society of Allergy website called Choosing Wisely on testing, and I'll put the link on my own website as well, which talks about these tests that are not validated. And so the things that they will do is they will analyse your hair. If you just think about that sensibly, like that doesn't make any scientific sense to analyse your hair to figure out what you're allergic to. Or they will do kinesiology or Vega testing, where they get you to hold a metal bar and do some sort of energy flow to see what you're allergic to. Or sometimes more worryingly, they will take blood from you and send the bloods off, but they're looking for the IgG, and that is not a validated way of telling you that you're allergic to something. Now, I completely understand why people go and look for these tests. They go usually because they're desperate, because they're not getting the answers or the help that they feel they need, often from their GP, which is a sad state to be in. So the sorts of people that will consult will be people with chronic problems with tummy problems, with diarrhea, with stomach pains, with fatigue, people who keep getting hives and swelling without any apparent reason, people with eczema perhaps, and they will be feeling desperate, and that's why people go to these clinics. And then generally what you're told is to cut out all the foods that cause irritable bowel, so things like gluten, wheat, milk, garlic, broccoli, spices. And as an adult, to some extent, that's fine. We can do that. It's not easy to do that. I wouldn't want to cut out all my chocolate, but you can do that, and we can probably live with it, and it probably won't cause us too many issues. But I have serious concerns about children being told to do that. It can affect their growth and their nutrition, cause deficits in certain vitamins that they need, and it really isn't advisable. So even for yourselves, please don't cut foods out willy-nilly without perhaps talking it through with your GP first, or maybe a dietitian perhaps, okay? So what do we look at? So first of all, the things to remember are that the testing only exists to look for IgE allergy, okay? And IgE allergy occurs when the immune system has gone awry and is reacting to something that should be harmless. So it's reacting to peanut that we should be able to eat without problem, or you're reacting to a cat that shouldn't cause us a problem, it's just in our environment. And the immune system going awry then causes very specific signs and symptoms to occur. So if we look at the skin, it will cause you to have hives or swelling and itching. If you look at the gut, it will sometimes have swelling within your mouth. Your mouth might get very itchy. Your lips might swell up. You may get immediate onset of vomiting or diarrhea or tummy pain. And if you look at the respiratory symptoms, you can get what looks like hay fever symptoms, so sneezing or congestion, itchy eyes, runny eyes, eye swelling when you're exposed to the food that you're allergic to, or the pollens, etc. that you're allergic to. And then, of course, you can have signs of anaphylaxis, so issues with your airway, so coughing, a hoarse voice, dribbling, issues with your breathing, noisy, wheezy breathing, issues with your conscious level or your circulation. So you might get dizzy, you might go clammy and pale, you may collapse. So signs of anaphylaxis. So first of all, when we're taking an allergy history, we're finding out, do you have any of those specific signs and symptoms? Then there's a timing involved. So if you're allergic to something with an IgE reaction, it usually occurs whilst you're eating the food very often. And that's because our immune system is primed and ready to go when we're allergic to something. So the IgE against that food that you're allergic to is literally floating. And as soon as you eat the food, the immune cell binds to that food and it causes this massive cascade of chemicals to be released. And that's what causes you those allergic symptoms. So it happens within minutes to an hour or two after exposure to the food, and the reaction fully resolves within an hour or two. So if your signs and symptoms haven't occurred till the next day, or they last you for a week, then really we're going to be looking at another reason for why you've got those symptoms, okay? You can get late reactions. So sometimes people with an allergy may have an immediate reaction that might settle. And then a bit later, usually about 6 hours later, but it can be variable, the reaction occurs again. And that's a late phase reaction that, a lot of people worry about, but it's actually not that common. It affects about 10% of people. But in practice, I often see it even less than that. And there's about reproducibility. So when you have an IgE allergy, it occurs every single time you eat the food. So you don't get away with eating it one day and then not the next. And then the next day you're okay and then not the next. It doesn't happen like that. There are some caveats to that. So people with like egg and milk allergies may be able to eat foods that are very well baked because it breaks down that protein, but they can't eat it in its raw form. So you could eat a biscuit that contains baked milk, but you can't eat a yogurt, for instance. But mostly if you're allergic to peanuts, you're going to react every time you eat peanuts, okay? So as a GP, we could do an IgE. So let's say we're talking to peanuts. So I'll do an IgE to peanuts, okay? Because you've given me a clear history. So the first thing is I'm only going to go do the tests if the history tells me that I'm suspicious you're allergic. So when I do the test, it will come back as a grade of 1 to 4, and it will come back as a number. And all I'm really interested in is the number. So if it's over 0.35, then it's positive. The most it goes up to is over 100, and that's fine, and that also tells us it's positive, but it can be anywhere along the spectrum. Now, people say to me, how do I know whether I'm going to get anaphylaxis? And is it that the larger the size of my blood test, the more at risk I am of anaphylaxis occurring? And the answer to that is no. Unfortunately, we can't predict when anaphylaxis is going to occur. There are some things that make it more likely. So if you're asthmatic, you're more likely to have anaphylaxis. If you're poorly on the day you eat the food that you're allergic to, you're more likely to have anaphylaxis. But the size of your blood test or the size of your skin prick test doesn't tell us about how severe your reaction is going to be. So as an example, Ethan that used to have anaphylaxis on some occasions to milk, his IgEs to milk were about 6, so not that high in the scheme of things, but he had anaphylaxis. So just because one child's got IgE of over 100 and another's got an IgE of 6, it doesn't mean that you're more likely to have a severe reaction. As allergists, we use it. We look at when you come to us with an allergic reaction, what was the first reaction? How severe was it? We look at your IgE, how large is it? The bigger it is, it may say to us, there's less likelihood of you outgrowing it. But it's only a likelihood. People still do outgrow it with IgEs of over 100. And then we use it over time to track, is your IgE going down? And if it becomes negative and you have a negative skin prick test as well, then is there a point where we could perhaps retry you with the food? Somebody wrote and said to me, why don't we track them regularly? So what you might know if you're in the allergy service is that we tend to see you every 2 or 3 years. And it's really, I guess, about probability of things are not likely to change quickly when you're a child in terms of allergies. So we tend to see you every couple of years. There probably is something in it in that we just don't have capacity to see everybody as it is. And you might know from your waiting times locally for your clinics, you're usually looking nowadays at 8 months at least, often up to a year sometimes. It's not great, and it's even worse for adult allergies. So because things don't change very quickly, we tend to see you every 2 or 3 years. You may find in a private setting you can have it done more regularly, maybe yearly. Some things do change quicker than that. So milk and egg allergies do tend to resolve very quickly within the first 5 years of life. So many clinics will see egg and milk allergies yearly until they reach school age, because things change quickly. So they may have their tests repeated more regularly. But other than that, on an NHS service, you are looking at having it done every few years. Skin prick tests, there is a whole video of what are they on my website and my YouTube. But they're very nice. They're done in clinic. People will off in a community setting or a allergy clinic setting. And it's tolerated by many people. Babies tolerate it really well. They often don't even wake up. Adults tolerate it well. Children tolerate it well. My tricky ages are the toddler ages who've had it done before, because they know what to expect, and they have to have their arm held still while you're doing it. And because they don't like that, it's not that it's painful, but they don't like being held still. That's often when it's a bit of a challenge. So you need to use some distraction, like blowing some bubbles. The only group that I've really found it challenging with is children with special needs. And in that case, they often don't like the sensory component of having their arm held still for a long period of time. And I often find that they would be better with just having a one-off blood test, which is quicker often to perform. People say, what's the lowest age that you can do it on? And the answer is, there's no lower age. So if I really was concerned about a 1-month-old having an IgE milk allergy, really, because that's all they're going to be having, then I would do a skin prick test for them if I wanted to. Generally, you're not going to do it on a child or an infant who is not eating that food. So I'm not going to do allergy skin prick tests on a 1-week-old baby who's not eating anything other than milk, because things will change. It might give false reassurance. It might also be a way of which I'm exposing the body to that food, which I don't necessarily want to do. So I'm only doing it either when the person has eaten the food and has had an allergic reaction, and then I'm confirming what I'm already suspicious of, or for some children who are at high risk of allergies, and those are usually children with strong family histories or children with very difficult eczema. They are at higher risk of IgE-mediated egg and peanut allergies. Then for them, we may look at whether or not we do skin prick testing before the food is introduced, to potentially then identify whether they're going to be at risk of allergic reactions. Now that comes with some issues. So whenever I have families like that in clinic, we always talk clearly about what are the pros and cons of allergy testing, and whether we test. The reason for that is, with any allergy test, just because the result is positive, it doesn't mean you're truly allergic. And that's why I say to people, why am I going to do tests on you without a history? Because it might show me that you have positive allergy tests to lots of things. But unless you give me a history that when you eat that food, you get hives, swelling, vomiting, diarrhea, anaphylaxis, it doesn't mean you're allergic. Or it might be that you're positive to cats and dogs, but you might say, I can cuddle my cats all day long and any cats and I have no problems. Then again, it's just a falsely positive test. It doesn't mean anything. And if you have tests done without any IgE-mediated allergy symptoms and they come back as positive, and this particularly happens in those with eczema who are what we call sensitized. So they produce enough IgE in their blood or in their skin to produce positive tests, but without necessarily having history of allergic reactions. But if you then tell that person with eczema to cut those foods out based only on positive tests and not actually based on allergic reactions, then there's then the possibility that they will develop an allergy because they will lose the tolerance that they formed against those foods, and allergy may then come on. And that particularly can happen in the younger groups. When you've had foods cut out for more than a few months, there is a risk that we will allow allergy to form. So allergy tests have to be done by somebody responsible who knows what history they're taking and knows whether it's relevant or not to be doing the test. If you just do blanket tests to say, oh, let's just do all the foods in the world and see what you're allergic to, then that actually can cause harm. And I'm not in the business of causing harm to patients and people. So I only test in conjunction with the history and after a full discussion with somebody about the pros and cons of it. Just so you know, to kind of complete on the different types of testing, a food challenge is done in a hospital setting. you go into hospital for half a day, and essentially by the end of that session, if you've passed the food challenge, then you should be able to eat a normal size portion of that food for your age. So a normal amount of peanuts, say for a 2-year-old. So you start off by having a very tiny amount of peanut, and then you're being monitored over 15 minutes to see whether or not they have any signs of allergy. If they are, of course, the challenge is stopped and the reaction is treated. If they don't, a little bit more is given and they're monitored again. If that's okay, they're given a bit more and a bit more until they pass the challenge. And then at that point, we would say, okay, you can go on and eat it at home. If at any point they react, if it's a mild reaction, they'd just be given some antihistamine. If it's a severe reaction where they need adrenaline because they're having anaphylaxis, then if the person is old enough, usually the allergist would encourage that person to give themselves the adrenaline auto-injector. If they're a young child, we would usually encourage the parent to give it. And the reason is then in a supported environment, that person or the parent is encouraged and shown how to use it in a calmer environment. You've got professionals on site, and it can actually be a really useful, positive experience then of knowing, do you know what, I actually can manage this anaphylaxis, and the adrenaline pens didn't hurt as I thought they would, and the needles weren't as sharp. And often people who have undergone that experience say it really wasn't as bad as they were fearing that it was going to be. So we do hospital food challenges if you've given a really good history of allergic reaction and yet your tests are all negative. Then to make sure you can actually eat it safely, we may decide to do a food challenge. Sesame, out of interest, is notoriously falsely negative. So you might have a really good history of an allergy to sesame, but your blood test and your skin tests are negative. And in that case, we would usually either just say, look, I'm really suspicious you're allergic to sesame, so don't eat it, or we would do a food challenge to prove whether there was a problem or not. If we think you've outgrown the food allergy, then most foods, to check that you're safe to eat it, we're going to do a food challenge before we let you go off and eat it in the community, because sometimes people have negative blood and skin tests and still have a positive reaction. There are some caveats. So if people have not had severe reactions, they haven't had anaphylaxis, then sometimes we will do baked milk and baked egg challenges in the community with very clear instructions about starting with tiny amounts without necessarily having to do hospital food challenges. And that's really all about a capacity again, that, you know, food challenges are in demand. They take up a lot of time. You can only usually do a couple a day, and there just aren't the resources to do everybody. So you may find, for instance, in your allergy clinic, that you might have a child who's multiply allergic and that you really want a food challenge done to a food group that maybe is not particularly well eaten. Maybe let's say to mushrooms. And you might find that your allergist is saying, no, we're not going to do that. It's not about money, it's about capacity. That as you can imagine, it's perhaps more important that we make sure that children can be eating their peanuts or their milk or their eggs, and therefore we have to prioritise. It's one of the things that sucks about working for the NHS, to be honest, that not everybody can have the treatment they need. Now, sometimes if that child is multiply allergic and we recognise that actually even getting something like mushrooms into their diet would be a massive advance for them and open up their dietary needs, then they would go on and have it done. But sometimes we have to just say no because of capacity, which isn't ideal, but it is the NHS, unfortunately. So that's just to explain, because some people don't understand why they don't always get the food challenges that they need.